Thanks so much for having me here again. It seems like every time I talk in Louisiana, some crazy national things happens about vaccines, so you may not want to invite me next year. Show of hands for the trainees in the room, residents, medical students. Yay! Stand up. Everybody else, this is the current and future for America's children. Thank you, thank you. All right. And so, as you can see on the first slide, not only I am the immediate past president, but I am a proud Louisiana chapter member, and will plan to be so for the rest of my life. And there is my email address. Trainees, write it down. Things will happen over the course. You're wondering what the National Academy is doing. I'm wondering what to do with my career. You are not bothering me. It actually fills up my cup to connect with the future leaders for child health. So without further ado, I do have a disclosure in that my husband and I have shares in an electronic health record company, and our objectives really are to explain some pieces of the important demographics of child health, identify opportunities to persuade others why investing in those children is important, and then figuring out how we can message conversations so we can advance child health together. So let's start with who are the children. And we're going to see if we can make Slido work, so get out your phones because you're going to need them. So, who are the child population today? In 2024, children under 18 made up what % of the US population? Take your best guess. All right, people voted, are we in? Show of hands if you finished. All right, let's see. All right, what do people think? Still moving around a little bit. Okay, so it's interesting because what's coming from the audience is the year I was born, which was 1960. In 1960, children made up 36% of the population. In 2024, it was down to 22%. We are declining portion of the US population is kids, and if you remove immigrants, it's in the teens. So let's give that pause, and we're going to talk about why that matters. If you look at the age group demographics of this country, and if you think about it, my aging 65 place, this is baby boomers, we're taking off. What do we need to have Social Security and Medicare and our livelihoods and our, to thrive is a healthy working workforce, and that comes from the child population. So start thinking about sound bites and creating a way to talk to other people in your community who don't know this. Clearly this room didn't quite get it right. So that you can expect that your office teams, the people in your family, your colleagues in adult medicine have no idea what's really happening. You see in the news declining birth rate, but to actually see this population number, knowing that the future economy of every community depends on a healthy workforce, means that we have to invest in children, and to not do so, we are going to pay the price in our communities for the decades to come. So, it's also very interesting that this is not evenly distributed across the country. In your state, your child population between 2000 and 2023 went down 13%. So you are being impacted in a way different than Texas, which has an increasing child population, right? And so the economies of our states, when you start talking to your legislators and congresspeople about investing in children, we have found at the National Academy in this environment, talking to people about doing the right thing for kids doesn't move anybody. Talking about the fact that if you don't invest in kids, the economy of your state is in trouble, gets their attention. Okay, race and ethnicity. This should be no surprise to anyone looking around this room, and I'm sure looking around your own office teams and your communities. We know that the race and ethnicity of this country is changing drastically. And also, if you back that up into the 1960s, a bunch of those people who grew up where the country looked different are very threatened by what the country looks like today. And their hearkening to go back to what it was when they were kids is not a reality without significant injury to the entire infrastructure of the country. But it helps you understand their framing sometimes. I want to go back to what the world looked like when I was growing up. Those are the people in positions of power now. And so that is not a reality of where we live. Again, the percentage of US non-Hispanic white children under 18 is not evenly distributed across the country. So when for the trainees, if you end up going to work in some different states, it's important that you understand the demographics of the state that you live in when you start to advocate for the children that you serve. And it should be no surprise to anyone here that less than half of Louisiana's children are white. And that is very different than it looked like in the 1960s and 70s, where people keep talking about hearkening back to. So immigrants is also not very evenly distributed. I mean, look at the difference between your population in Louisiana and next door in Texas, and then in California. So the stories in the news and the things that are happening to our immigrant children and their families and communities is not evenly distributed, and so people may not understand what's the big deal, and part of that is they are not in Louisiana specifically exposed to this as such an important thing that's happening in your community. So understanding the framing of where your people live and what your own demographics matters. Okay. We know this should be something that you should know about, because that we know that even more than everything we do in our exam rooms and our hospitals, what is one of the single biggest factors of child thriving? Poverty has the biggest negative impact on their thriving of anything that we do in healthcare delivery. And so it's important to understand that to live in poverty is to have worse health, especially for children, and worse health outcomes, more chronic disease, shorter lifespans, et cetera. And so it is important when you talk to everyone in your community and your legislators that they really understand what childhood poverty looks like. I will tell you that when Social Security and Medicare were enacted, they were done so because the largest demographic of people living poverty at that time were seniors. That's why those programs were brought into focus, because seniors were living in poverty. We now know that the biggest demographic of people living in poverty is children. And so let's see what people think. 25% of children live in poverty, seems to be what's gaining traction here. And in fact, in Louisiana, a quarter of your kids live in poverty. 1 out of 4 children lives in poverty. That's an important statistic for everyone on your healthcare team, in your family, in the community, and your legislators to really understand that you can't move the needle on child health until you move this needle that affects 1 in 4 children. Okay, should be no surprise to you, but I bet it is to some, and I bet it is not even or people don't even know who are an adult medicine specialist. If you go to your adult Louisiana Medical Society colleagues and you ask them what percentage of children in Louisiana are enrolled in Medicaid or CHIP, 62% by this poll. That is huge. So no wonder you are all starting to feel, and will even more acutely feel, the impacts on reduction in Medicaid funding. More than half of Louisiana's children are covered by Medicaid, which is the largest insurer of children. Let that sink in, put it in your brain, and tell at least 10 other people who are not pediatricians when you leave this meeting. So, what percentage of births in Louisiana do you think are covered by Medicaid? And we know this has impacts on many things, including including maternity deserts, because if many births are paid for by Medicaid, which is underpaying for services, OBs leave the building because they can't make their numbers meet. Pediatricians just sit on the floor with duct tape and try to deal with crumbs to make sure that kids get care. So let's see what you all think. $52 seems like it's winning. The correct answer is 64. So over 60% of kids in this state are covered by Medicaid, and over 60% of births are covered by Medicaid. I would be willing to bet that that is not a statistic that comes out of any policymaker's mouth, and it is up to you to make sure they know it. This is a Medicaid fact sheet, which is available at the National Academy of Medicine, or American Academy of Pediatrics. We've made them for every state. These are leave-behinds that you can print off and hand to people to leave behind so they can sit with those statistics. The first slides that I showed are also freely available to reuse on the AAP's national website. In my references, there's links to them. Please use them and hand out those. They are powerful when they see the maps of what's happening in your state. This is from KFF, and this is also additional Medicaid in Louisiana information that is powerful to leave behind. One of the things that I thought was very interesting, considering all of the craziness we're now dealing with Medicaid work requirements for adults, guess what? Almost 70% of Medicaid adult recipients in this state are already working. So how much money are we spending on administrative procedures to make sure people jump through hoops when most of the people are already working? Okay, now we're going to get to not only is Medicaid funding, and this is especially important for the trainees because I need you to help me redesign healthcare delivery for kids to get us out of this hole. Not only are 2/3 of the kids in this state covered by Medicaid, when you look, and our adult colleagues keep screaming about we have to get paid better by Medicare, which is less than commercial. Commercial insurance pay the most. Medicare pays under commercial. And here is what fraction of Medicare rates we get in pediatrics for Medicaid. Again, we're living in the 60s, people. If you can't remember any other number from this talk, everything's right answer is somewhere in the 60s, right? Primary care is 60% of Medicare. So if your grandmother, and this is the story part, data's important, but so are stories. If your grandmother goes to see their doctor with a sinus infection and is covered by Medicare, and it's not this amount of money, but just for comparison sakes, and that doctor gets $100 for that visit. If a child comes into your clinic with Medicaid and has the exact same work done, except I would argue it's harder because they can't be their own historian, and you have to deal with two caregivers who sometimes don't live together and don't agree, you get $60 compared to the $100 for the exact same work. So when you have Medicaid paying at 2/3 of Medicare, which is less than commercial, and 2/3 of your kids are covered by that insurance, the math doesn't work. And that is why we are struggling, and we need to figure out how to reinforce that. That doesn't translate to us not driving Ferraris. It translates to us not having the right ability to have the resources to take care of kids in our communities and in our practices. So, why does this matter, and what can you do? Again, I can't overemphasize when you talk to people about this, today's children are tomorrow's workforce, and some people will be like, yeah, that's 20 years later. That's true for the newborns. It's not true for your 15 and 16-year-olds. They are the next employee applications. And so we have to remember that this is also near term, not old term. Today's children are tomorrow's military readiness. If you have policymakers who care about our country's military strength, there was a study 3 years ago that of young adults who volunteered and applied to the military in this country 3 years ago, 77% of them were found unfit to serve for either physical reasons, mental health reasons, or both. Almost 80% of applicants were not healthy enough to be accepted into our military. Anybody know where EPSDT came from? Early periodic screening, diagnosis, and treatment. Vietnam War, we did not have a military readiness workforce. We were not quite this bad, but we also had unhealthy children. That's where that whole program came from. So for your policymakers who care about military readiness, especially in today's climate, we need to talk about investing in children to make them healthier so that we have that. And every community deserves a strong economy. Lead with that, but that depends on a healthy workforce, which means we need to start investing in children. And again, Medicaid is the primary health insurance program for children. So connect these dots. And I would say start with your healthcare team. Anybody in the audience have recent conversations in the last year with your entire healthcare team, starting at the front desk check-in, the billers, your MAs and nurses, about what is happening to the health of children and Medicaid and all the implications for our child health? Anybody? If our teams don't know this, then shame on us. Right? We have to start with our own house. When someone calls your office for an appointment, the physicians are the last person in the room. They've already had 80% of their experience up front. We have to empower our own teams to understand what we know about what children need to thrive. And then we have to talk to ordinary citizens, your family who are not healthcare people, someone in the coffee shop, your child care people, your house of worship, whatever it is, and policymakers. We have spent too much time talking ourselves and not turning outward. And so please take my call to action and make this be tell two friends who tell two friends who tell, pick whatever you want out of this, but we have to start talking about the demographics of children, how it relates to child health, healthcare financing, and how we get to a better place. So this is something that also I think is important, and people are not connecting the dots. Why do Medicaid cuts harm every child, not just kids on Medicaid? So here it's 60-some%, but across the country, Medicaid and CHIP cover almost half of the children across the country, right? With this decreased Medicaid funding, what's going to happen is the states are going to be left to fill the budget gap. From what I know, Louisiana's not rolling in dough. So I don't think your policymakers are just going to print more money to make that Medicaid budget cut. I don't think any state's planning to do that, right? So what happens When everyone who's getting paid by Medicaid and that pool of money shrinks because the feds aren't giving the states as much money and the states don't have the money to make it up, and they are legally bound to have a balanced budget. You've already been in the middle of some of those horrible conversations, right? So what happens? Payments to participating healthcare entities go down. In North Carolina, they put a 4% across-the-board cut for all Medicaid payments. We're already underwater, and in primary care, outpatient pediatric independent practices, we live on about a 4% profit margin. They just sunk every independent practice in North Carolina who takes Medicaid. They can't make the numbers make. You can't deliver care for less money than you're paid, right? They cut enrollees. If we don't have as much money, we figure out any which way to make sure we're not covering as many people, like all these administrative hoops that people have to jump through to prove that they are working or to prove that they have a condition where they're not allowed to work. So who's going to make that medical determination about whether they're medically fragile enough to not work when they don't have a doctor to go to because there's no access? We're in a loop, right? And then there's benefits. There's programs across the country that are completely cutting ABA therapy for Medicaid kids because they have to figure out some way to make a budget cut. This is not our fault, but it is our problem. And if there is no margin, you have no mission. You fold up. It's why we're seeing some healthcare payers leave markets, because the money, you just can't make the math work. You can't make, negative numbers with more patients add up to something that's sustainable. It's just not. So again, connect the dots across healthcare teams, ordinary citizens, and policymakers. Your healthcare team in your practice doesn't know this either. And so they're going to be coming to you saying, why are we working short? Why are people being denied claims? Why? Let them understand the backstory so they can also talk to their policymakers about, you got to get us out of this hole. Okay. There's another piece to this that is very important to connect. When you have top-line cuts, anybody does this, if you have a budget, you have a checking account and a budget, and you try to figure out how you're going to make your money meet to the end of the month, right? When you're cutting at the top line, you have to cut somewhere further down the line. So top-line cuts lead to decreased beds. There are hospitals, including children's hospitals, who are going to say, we're not making money. There's not enough margin on these hospitalizations for X, Y, and Z. We're going to convert them to CT surgery beds because they make money for the hospital, but the pediatric mental health beds lose money for the hospital. So, or they're going to say, and it's happening in places across the country, our children's hospital is going to cut our community outreach programs because they're costing us too much money. So guess what happens when you start cutting all of those services and you cutting payment to healthcare teams? It doesn't matter if your kids and grandkids show up with a commercial insurance card. If the programs have been cut because they were not able to be fiscally solvent, it doesn't matter what kind of insurance card you have. There's no pediatric expert there to give you care. Or you're waiting for 2 years for an appointment to see a developmental pediatrician because they couldn't make any money on their bottom line. And so we need to connect the dots. People hear about maternity deserts. These threats to Medicaid are going to make us have very disparate access to medical care for kids across the country, and rural areas are really threatened, and the rural health funds that the grants that they're making don't even come close to making up for the budget shortfalls that were happening. I pulled this off of a RAND study, so if anyone from Manning Family Children's Hospital who wants to correct me, please do. But in 2023, Medicaid was 71% of the inpatient day share for kids in Manning Family Children's Hospital. So if they get cut rates, They have no choice but to have that impact somewhere down the line. So, connect the dots for everybody concerned. Okay, let's talk about hungry kids. Take away their health care, take away their access, and now we're going to take away their food. One thing that I have learned being on the national stage is when you talk about food insecurity, it is politically charged. People tune out to everything else you're saying, and all they want to do is talk about how you're, waste, fraud, and abuse. If you talk about kids going hungry to bed, it paints a totally different story in people's minds. So these data are important. These are Louisiana data and the change to the population. You have way more hungry kids than you did before the cuts to SNAP. And school lunch programs. You had many great schools who decided that community eligibility, there were so many kids that qualified for free and reduced school lunch that you would spend more money administering the program to decide who was eligible than just giving every single kid access to free lunch. That is true across the country in many places. And we know that it works. There are school districts that have spent enormous amount of money trying to figure out who qualifies and who gets the right access to lunch, and people requalifying every year. Just the administrative burden costs more money than feeding all the kids in the school. That's exactly the same tactic they're using for Medicaid work requirements, by the way. Okay, you see this in your practices. Percent of children, let's talk about some of the health concerns and what's driving their health. We are seeing more and more mental health diagnosis. I am happy, however, to report this only goes to 2023-ish, 22. We have turned the corner and seen a little bit of a dip in depression and suicide since 2022, and a lot of that is, I think, on work on your behalf and understanding and highlighting the need to support our young people. Leading causes of death of U.S. children, this is just 22 and 23. This is 1 to 4. Look at the green line. Unintentional injury. Despite everything we do, some of that's gun violence, some of it's drowning, some of it's motor vehicle accidents, but that is something, parent worries about their child getting cancer and dying of cancer. They are much more likely to die of an unintentional injury, which we should be able to prevent. This is 5 to 14. Notice the unintentional injury going up and suicide. And this is the teenagers. And a significant part of that green bar is firearms. And so we've learned to talk about reducing the risk of gun violence and gun violence prevention. This is not about taking, and don't let anyone turn the conversation to taking your guns away. No, we want research and data to drive how we keep our kids safe in the current environment that we have. There was a policy statement that's not in too recent past about the firearm-related injuries and deaths in children and youth. And again, talking about injury prevention and harm reduction, not talking about taking away guns. There's a technical report that went with this, which is fabulous and packed with state-level data if you want to know what's happening in your state. Here is information, and now that is too small for me to read. Suicide. That is suicide and hotspots across the country, which is frightening, and that is homicide. So knowing where you fit compared to states, and I have found that usually state-level policy makers like to be told that they are leading the nation in things. So if you want to try and get a firearms safety prevention work going in your community. Talk about how we can turn this around and be the leading state in the nation for keeping our children safe, and figure out how you lead with those kinds of conversations. But it is you showing up every day, doing the work you do on behalf of the chapter in your clinics, in your hospitals, that are making a difference. And this is something we should be proud of, and we've been working out for decades. We know that breastfeeding leads to better child health outcomes, and we are getting better and better steadily at working at this. So kudos to all of you who are talking about it, recognizing it, and supporting moms in breastfeeding efforts. I want to turn for a second on how we're thinking strategically at the National AAP. It used to be that every year we had 4 strategic priorities of what we were working on important to child health. Well, we are no longer living in an environment where we can plan for what we'll be doing the next 4 years on child health matters. Because if you had asked me 2 years ago, would I be fighting for Medicaid and fighting for vaccines, I would have told you that you were crazy. But that is where we live in the current environment. And so we're shifting our thinking about using a guiding compass to making decisions. What are we going to prioritize? If we have limited resources, what are we going to work on? What's the implications? And the National AAP has always used children and children's health as our North Star. That will never change, but it's not enough. Because if you don't support members and what they need in their practices and their hospitals, and if we don't pay attention to the workforce and the profession of pediatrics, and we don't pay attention to the organizational reputation, because we have a huge target on our backs, because we're one of the few organizations that has been bold and brave enough to stand up for children. And so all of that work is important. All of those compass points are important, and it is all grounded with equity at the center. We need to make sure, and we are proud to still talk about health equity and equity in our workforce and equity in our work, even in places and spaces where we may increase the target on our back by doing so. We are not shying away from what is important, and that is that every child deserves the best outcome, and that means we have to be honest and look at the unequitable distribution of resources and health in this country. Okay, couple of cool things that happened this past year. Not everything is doom and gloom. Many of you know and have been helped us work on at the national and local places, how do we keep kids safer online? And there's been efforts, and the Kids Online Safety Act has gotten bipartisan support and never made it across the finish line 1,000,000 times. And so, as I heard someone say, well, parents should be able to parent. You cannot out-parent an algorithm. We can't even out-professional an algorithm. And so the tech companies were not taking seriously what we talked about endless scrolling and features that really just keep kids addicted to screens and social media. And so Apple is designing in some of their updates this fall programmatic ways to put our AAP guidance into the hardware. If the software guys won't play by the rules, the hardware guys are going to put hard stops in there. So parents will be given the ability to limit the total amount of kids' time that they're spending on social media. And most of these kids have these iPhones in their pocket. So this is a great first step for us to partner with big tech to make sure that we can take what we've learned through the research and make sure that every kid has safeguards in front of them to mitigate the damage and the harm that we know is happening from social media. And a side note for any of you who know our CEO, Mark Del Monte, he got fanboyed because he got called out at the Apple rollout of the new features that they do every year, and he was on stage with Tim, and he thought it was awesome, so you have to ask him about it the next time. But it's a big deal for all of a sudden the AAP and pediatricians to be talking to big tech about what we know is best for kids. And then there's leadership. Thank you to your leaders who showed up at the leadership conference. For the trainees in the room, there is a leadership conference every summer at the AAP headquarters, which brings together all of the chapter presidents, vice presidents, people who are leaders in state chapters, people who are leaders in other aspects of the American Academy of Pediatrics, like the section on pediatric trainees. And if you're not a member, please do so by the end of this conference. It is a great resource for you to find like-minded people to solve problems and build a plan for the better world for pediatricians and kids for the future. They are always the highlight of this conference. The pediatric trainees, any member, any AAP member can say to the AAP, here's a problem I would like to see the AAP address, here's why and here's how. The pediatric trainees are always the most poised, well-spoken, and practiced people that many of us could learn from. And here are the top 10, those leaders then, after we vote on which things should be adopted. These are advisory to the board. They're not the board mandates, but the board watches the whole process very intently, and we listen to what our members are prioritizing. I love that the first thing that came out of this, the #1 priority, is addressing structural pay inequities affecting pediatric professions. So we are finally saying payment out loud in every space that we can, because it is directly adequate payment for pediatricians, means we have adequate resources to care for kids, which is more important now than ever, and it also impacts our future pediatric workforce, because people coming out of training with enormous debt can't make the math work in a pediatric profession. And then if you want to go to a specialty and go into developmental peds or rheumatology or ID and make less than a general pediatrician after longer training, it just doesn't make sense, and our kids deserve better. So we are prioritizing smart people in a room, trying to figure out what are the levers we have, and not looking at what we can do today, because that doesn't look very promising, but planning ahead 2 years from now, where we might be in a place to be able to talk differently about this. Although I did see that there's a bunch of people who just sued the AMA for CPT rights, and there are some people in government who want to shake up the way the CPT and RVUs, how we value all of the work that we do, which is ultimately what pays us. I'm happy to apply for that position if they want to be shaken up and reworked. Personally, I think that we should have a modifier that means we get paid 1.5 times what you do for adult care, because we have an inherent care coordination issue, because our patients are not self-directed and not able to adhere to their own care plans. But there's lots of information in there. Fixing Medicaid, getting rid of the middlemen, and there are think tanks already happening at the AAP where we've talked about how do you everybody wants to get a piece of this and make their money, and whether it's PBM or other things. If we went and got rid of the administrative middle and made it the same across states, so kids don't get to pick where they live, why should it matter if a kid gets different care because they live in Louisiana than they would if they lived in New Jersey? It's not fair to the kids, and it shouldn't be that way. And so we're looking creatively at all of those things to make sure, and there will be responses coming over the next year. Okay, kudos to your chapter who's gotten involved in the Vaccine Confidence Campaign. You are going to hear a little bit about this from different speakers, and Paul Offit tomorrow. Please be here when he does the keynote. He's coming in remotely, but he and I have spent a lot of time texting back and forth crazy emojis over the last 18 months. But there is a lot of work that we've done in the academy, and your chapter is doing, to really change the conversations, to meet families where they are, to get the information that they need. And that includes your back to school campaign, which is fabulous, and you should take advantage of as much of that as you can. I want to pivot for a little bit because I think we have a pivotal moment in time here. Healthcare delivery is broken in many places. In some ways, because we've moved from transactional care, I'm here for your sore throat, I'll swab you and give you an antibiotic, versus relational care. I care about you in the context of everything that's happening in your family. And the root of all of that relational care is trust. Well, we know how to do this, people, as pediatricians. You get new parents who are scared bejesus with an infant in front of them to trust you. You get toddlers to trust you to look in their ears. You get teenagers to trust you and say things that sometimes you don't want to know. But they trust us. We understand how to build trust and strengthen trust, and we have to use our superpower in order to make sure we get out of this conundrum. Of all of the distrusted people in the country these days, pediatricians are still the most trusted. So use your superpower. Don't hide it under a bushel. Get out there and use it in every space possible, including in exam rooms one-on-one with your team and with your communities. But there's 3 components of trust that are essential. One of which is they have to believe you're competent, you know what you're doing. They have to understand and feel like you are acting with integrity and compassion. And here's the thing I think we could work on, and that is consistency. We have trained our healthcare systems to be efficient, first available appointment. That does not give you a relationship with somebody over time. So think about removing barriers in the way that you schedule families so that you can develop a relationship over time. And you know what? You can even automate some low-hanging fruit that makes you feel consistent without a whole huge lift. What if there was a personalized, triggered email from your system or a text 2 days after your first new patient appointment said, hey, thinking about you, it was great to meet you. There's lots of new patients who have unanswered questions. Here's the great way. Here's multiple ways you can get in touch with me, right? For trainees in the back, hospital care. Meeting people where they are from a human standpoint first. When you sign out, here's the patient's weight, here's their allergies, here's their med list, here's what they're on. What about signing out, they have a poodle at home named Buttons. And you sign that out to the next person who walks in and goes, you have a poodle at home named Buttons? I had a poodle when I was little. All of a sudden you went from being a transactional, I'm in the hospital caring for your problem, to you're a human who I care about. And it is remarkable how you also feel humanized, and it makes you ground yourself in humanism before you get into the entry of your reason for your visit. So connect human to human, make 0 assumptions. I've heard from some pediatricians that they see a 2-month-old on their schedule and they go, the vaccine conversation. Don't assume anything. We used to say that about people who wanted antibiotics for a cold, and now I no longer have a sigh before I do that because people are like, I don't want antibiotics, it's gonna mess up my microbiome. So understanding, leave all of your judgments outside the room, walk in, make no assumptions, ask questions, and then wait for answers. Physicians interrupt patients within 7 seconds the majority of the time. Because our head goes to, I know what's wrong with this patient, I can get to the diagnosis, I can get to the treatment plan, and we've missed the whole relationship part of the trust building in the beginning. But that means the people who schedule appointments have to give you more than 7 minutes to do it. So, if I learned one thing last year, is to listen to messaging experts. Because we think we know what patients want to hear. We are talking to ourselves half the time and not reaching our intended audience. So, parents don't want to hear that they're confused. They're understandably overwhelmed by conflicting information, as am I, right? Herd immunity, and it's come up in the news a couple of times, our messaging strategists tell us they feel like that's cows. It's community immunity. We want to talk about keeping our community healthy and community rates. Normalize immunizations. Don't assume nobody wants them. The vast majority of American families understand the value and importance of vaccines, which are safe and effective. And emphasize partnership. Parents don't want to hear that we're the experts in child health. They are the expert in their child. We have special knowledge and experience, and together we can partner to help your child thrive. That's what they want to hear. That's how we build and strengthen trust, using language and words that matters to them, not matters to us. There was a big campaign early in the vaccine space last year where we said, call your pediatrician, and we still say it. I will tell you, if you're in Appalachia, West Virginia, they were angry because the pediatricians left those zip codes a decade ago. And so don't say to me, call your pediatrician, you abandoned us. So we have to be careful about nuancing the message for the place that we're serving. Don't say that in zip codes where there's hardly any pediatricians. Figure out a different way to get access and the message to resonate. And even better, partner with people who are messaging social communication scientists. Next year, maybe you can get those guys to volunteer at your meeting to help you out. They're looking for projects on how social messaging and communication matters. Go find some undergrad or grad students who want to do a project with you to figure out which messages resonate with your communities that are going to matter and move the needle. Mis and disinformation works in this room. Don't say it to families. It is also a politicalization trigger for some people. Talk about harmful rumors and harmful lies. Don't talk about all pediatricians. When they fired ACIP, some of ACIP got replaced by pediatricians. Not people who I want to be friends with, but pediatricians nonetheless. So talk about your practice and my colleagues and I and my organization. And then be wary of leading with fear because people really want to feel hopeful. Talk about learning, playing, thriving, and listen first and then deliver the message. Okay. There are people out there who do messaging for a living. Some of that work is being incorporated into your chapter work. This is a great resource for people looking at it on this hepatitis B conversation about the first birth dose. If you're looking to find tested messages that have worked and moved needles, there's also one on vaccine policy if your practice just chooses to not accept people who don't vaccinate at all, or if you do, just talking points that not are talking to us but are talking to families. All of these resources are in your slides. And then, vote. The only way out of this is to elect public officials who understand what we understand, but that means not only do we have to vote for the right people, we have to empower all the people to know what we know about what the health of kids depends on and what we need our policymakers to do, and we need to elect the people who value kids and kids' health the way we do. So please do that. Opportunities. Oh, and by the way, if you haven't already done so, figure out how you give your trainees, if they're licensed or if their address is in their state, of time to vote. Figure out how you get your team members time to vote on voting days. Like, we can't be the barrier to getting our people out there to vote. That cannot be us. We need to remove all barriers to make sure that happens. But we lead with our hearts. That's what we do. That's our superpower. Parents want that connection. Don't hide behind it. Lead with it and embrace it. Channel your inner toddler and ask questions. Be that 3-year-old who just says, so where'd you hear that? Let me learn more about that. That's interesting. How can I help you? Instead of coming at them with information, ask curious questions. realize that you're going to have to plant seeds that you may not see the fruition of until measles is in their community, and then they finally say yes to the measles vaccine. Planting seeds matters. Engage in your community, medical community. Again, our adult medicine colleagues think that this vaccine issue is not theirs. It has to be everybody's, right? How many adult medical providers give vaccines in their clinic now go to the pharmacy? It's not really my problem. Well, it is your problem when you're going to see all the kids who are harmed who end up seeking you for care when they age out. And then engage in your social community. That's your family who's not in medicine. That's the people who use the same daycare. That's your faith-based community. Because remember, not everybody has exposure to a pediatrician. And so we can't be the only voice. We have to be the conduit of messages that we empower people to spread for us. Your role, trust your strength and trust, know your audience, and use those words that will resonate. Use your voice to tell the story. Use data and stories, and then contribute to chapter efforts by being able to do that. So there are some MOC questions, which I am not going to go through, but in the interest of time, but you can look through them and be able to do them. So. Remember, the equity, this is our compass of what's guiding all our decisions, share what you know, center yourself, make connections, make a plan so your team can vote, and then just a few minutes about late-breaking news. Early last year, I had a spreadsheet of all the things that the current administration was going to do to ruin the vaccine infrastructure. Some people called me a catastrophist. Now they're calling me the realist. And so a couple of things happened. The AP is making recommendations for kids, but we are actually putting out there in bold how we are doing this process. Since we don't have ACIP and we don't have ACIP work groups, we have outlined, put it in the public domain, so if people say, well, I don't trust the AP's process, point them to this page. This is our process. We are transparent. We will tell you how we do things. And because we fully expect the vaccine information sheets, which we are legally required to give patients every time they are vaccinated, are going to likely start containing harmful lies. The Academy, you still have to give them, but you can give it under a big pile of papers where you put this one on top, which is immunization fact sheets. We just released the flu one. If you see that download button there, you can download it for yourself. That's what it looks like. It's way more compelling than the black and white VISs. We hope to make videos and other things out of them. RSV and COVID just got approved. When those policy statements come out, they will be attached. And in view of the executive order that happened last week, we are fast-tracking the entire rest of the vaccine schedule. So start preparing your organizations to make sure these are prioritized to delivered, to give our families facts that they can trust in a way that has been tested with them to make sure we're giving them the right information. Lots of references and additional information, but keep showing up, guys. Thank you so much.
Don't go anywhere, Sue. So if we're going to take a few questions before we go to lunch, you can drop your questions in Slido, and then we'll take 2 or 3 questions for Dr. Kressly. Now, I'm going to blow her mind, something that she had no idea happened, but we are now at 85% of Medicare in Louisiana Medicaid. Yeah. I'm going to shout out to Stuart Gordon. He was behind that, gave us a lot of support in increasing us from 60% of Medicare to 85% of Medicare.
That's awesome.
So we did get a promise to go 100% of Medicare, and that went nowhere, but 85% is better than 60.
Is it at risk?
So, what's that?
Do you think it's at risk this year with the cuts?
No.
It's written into statute.
It's, Stuart, can you answer that?
Or how are they going to balance the budget?
If they want. It went through the legislature, so we're okay.
Still, kids are not 85% of their grandparents.
No, they're not.
And especially with your high Medicaid coverage rates of 60 plus kids, that's fabulous. Those slides are clearly a little bit.
Yeah, they
up
haven't
to
made it into the references yet, but our physicians are getting the benefit of that. Do you have any questions? Anything at all? It is
Only for
codes.
certain codes.
Yeah.
And is it for so it's certain CPT codes for E&M and well visit services?
Yes. All right, so while we're seeing this, I'm sorry, go ahead. She said she'll pay for them.
Yeah, no, you got to wait until January when I'm no longer in the executive line. There's a lot of stuff in my thought bubble. I might write a book. That might be interesting, but there you go. So somebody asked a question about the changing race. Are those made after the recent changes? No, that's going to completely totally alter the number of kids and the race and ethnicity. We know that. We also know through a places study, and the resources go back to the AP, that at least a quarter of the pediatrician workforce is either first generation, was not born here, or at least one parent was not born here. So we also reflect what our country's demographics and all of the barriers they're putting on visas and ability for immigrant physicians, international medical grads to come here and join us in this work is threatened. So have no idea except lots of large question marks about what this looks like in 2 years. But I don't think it's going to be in the best interest of our profession or children.